of all, thank you very much, Dr. Nagesh. Uh, Almost 2 months since last, I think 9th of April, we admitted first patient in our center, and almost 2 months are going to be over on next 2 days. Uh, everyone of my team, I think my department and everybody was working day and night just to make sure that patient should be safe. And so as even I was absolutely busy with them. It was a difficult day. It was like it was a difficult task to save everyone, and we saved many lives. I think very few. I think our the death rate of our center is almost 16 to 17%, although which was only 1.5% last wave, but this time the death rate was very high. So I was very much like I was giving everything very taking everything very minutely, where we can save, what else we can do, and this used to take all my hours day and night to manage things over there. With my team, whole of the team was working, all residents, all faculty, and everybody was working over there. So um, but I missed all the classes. IAPC Academy is also equally important for all of us, and I can see again almost 54, and after some time it will be 100 participants will join, and all of my seniors and everybody every day regularly they are joining, and I was missing these classes. So today I decided that whatever happen, I will start joining from today, and I will see if at all it will not happen, I will again request Dr. Nagesh. So thank you very much, Dr. Soumitra. Uh, I know the today's topic which Dr. Soumitra is going to tell us is depression in cancer patients. I think it is when we take rounds and we do anxiety depression score in all our patients, and what we found that most of the patients we found that they are almost 50% patient or more than 50% patient. Sometimes we say that depression score is very high, but it is always difficult to judge that whether it is genuine depression or it is because of the it is a genuine depression means because of the cancer they are depressed, or because of the any means like it's a chronic phenomena or psychiatric disorder, something which has to be treated by psychiatrist. So who can be the better person to teach us what exactly happening in the patients those are depressed in cancer patients. So Dr. Soumitra, Datta, we have worked together in one or two projects like lately with the DNB this thing curriculum, and what I have found that you Dr. Soumitra is always full of knowledge, and he gives suggestions, and when we discuss something he has an excellent suggestion for everything. He is a consultant psychiatrist in Tata Medical Cancer Center, Kolkata. He is a visiting researcher, Institute for Women's Health, University College London, and he is a lead reviewer of corporate collaboration. His other qualification is he is expert in child and adolescent psychiatry. I think we are really short of child and adolescent psychiatrists in this country, but I can see this. He has worked hard, and he has taken this qualification from UK. So probably it is really going to be useful for India. He has received many bursaries and fellowship award, and he is basically clinical role is lead psycho-oncologist services offering treating for cancer patients, their relatives and staff, which is very important. Again, for relatives and staff, I think we hardly bother, but it's at high time that we have to take care of their depression also. And his research interest is mainly psycho-oncology and decision making. So Dr. Soumitra, please start. Arun, please note down all the question answer, and we will take question answer at the end. Thank you very much.
Okay, sure, thank you.
Hello. Thank you so much to Dr. Bhatnagar for that kind introduction, and also to IAPC Academy for inviting me to be a faculty for this course, which has been running for some time now. I will try to make my presentation and interaction simple, because I think, um, instead of getting into various complications of treatment, I think if I can convey the simple message of how to identify depression and what are the barriers, that would help the IAPC, the MD palliative medicine students and others who are in the beginning of their journey. Um, I will share my screen. One second. Can you see the screen?
Yeah, we can. Yeah, we
Yeah.
can see Dr.
Yeah.
Soumitra.
So I work in Tata Medical Center, Kolkata, and I declare that I do not have any conflict of interest other than the fact that I work in psycho-oncology and would like all of you to take up the cause of mental health in cancer and oncology. Um, Now, what will we cover in the next few minutes is that, what are the barriers to diagnosis of depression, in particularly in palliative care, and how do you assess depression? How do you manage depression in palliative care setting? And why is managing depression important in palliative care? And we would do the second and the third objectives by discussing two patients. I will divide the group into two breakout groups so that you can discuss it amongst yourselves, and we'll talk about it more when we go to that point. Now, depression is the most common mental health problem in palliative care setting. Of course, when you look at depression, um, you do need to be sort of be mindful that the other diagnosis of mental health, like delirium, is, you diagnose depression only when you don't have other comorbid diagnoses like delirium, because there is a Fowler's hierarchy. So you first look at organic, and then psychosis, and then depression, and then anxiety, in that order. So because delirium is very common in medical settings, so I would say that, you make the diagnosis of depression when it's not there. And depression in medical illnesses often can co-present with anxiety symptoms, so that's again not uncommon. So the anxiety in palliative care setting could be around, anxiety about procedures, anxiety about future, worries about the family, worries about finance. So these are all very common. Now, there is a colloquial use of the term depression, which we all use in social interactions, and it's more so very poignant in the COVID scenario. Whereas what we are today talking about is primarily a disease called depression, which has an ICD code. So, uh, although we divide people into people who are depressed and people who are not depressed, and the value of a diagnosis in psychiatry is related to, interprofessional communication. So what I call depression, you should call depression as well. So there is a standardized diagnostic criteria. Also, professionals would like to have a threshold for intervention. So that's again a reason why there is a psychiatric, any diagnosis, rather than a continuum, a categorical diagnosis. But you do have to understand that nature does not know that. So you may find people who have depressive symptoms but do not fulfill the threshold of a depressive syndrome, and this is called subsyndromal depression. So it is actually a continuum, but what we would like to discuss is primarily the syndrome called depression. What are the barriers to treatment of depression in palliative care setting? One of the barriers is misconceptions amongst the patients or the family members, or the treating teams, minimizing significance of depression at end of life, and lack of clinical skills to distinguish sadness from clinical depression. And if we go a little bit into the details of this, some clinicians, and these are published data, do believe that it is completely an appropriate reaction at the end of life, or when somebody is in palliation. We all, as palliative care physicians, we know that we do get to see people who are absolutely coping fine when they're in palliation. Not everybody in palliation is depressed. Some believe, initiation of treatment may interfere with the coming to terms with death and dying. Again, this is another misconception. And patients, and family members and doctors sometimes are quite worried about side effects of antidepressants. And we will discuss a little bit what are the side effects and drug interactions you should be worried with, and what is the quick tips to run a checklist about what you need to do when we discuss the two cases. And we might be worried about these, and these may lead to under treatment and under recognition. Now, there is also some discussion around psychological treatment in depression and palliative care, and the value of formal psychotherapy. I am not saying that psychological treatment is not effective. It is very effective in palliation, and everybody needs to be talking to patients and family members. But a formal psychological intervention is something which has been tested in the paradigm of a randomized controlled trial. And I think there is less validated support for formal psychological psychotherapy. And there might be, sometimes time urgency, because psychological treatments also are formal psychological, it's like CBT, which goes on once a week session for 8 to 12 weeks, and you may not have 12 weeks to intervene in certain situations when we're dealing with palliation. Now, there could be also genuine sensitivity towards the individual's need, and clinicians not wanting to be too intrusive into people's personal lives, and clinicians may be uncomfortable probing death and dying. That's again not unusual, because as in when I went to medical school, I didn't have a single day lecture on palliative care. And it's or end of life care, or where treatment has failed. So I think it's important that the things are changing, and now the definition and the ambit of palliative care has changed altogether. And people are realizing, however much we develop medicine, it will never reach a stage where there will be eternal life. So even if you're not well, you will still be at end of life at some time or the other. All of us will be. So but this is uncomfortable to talk about it, to discuss and probe all this. So I think those also could be some of the barriers for psychological treatment. How do people deal with when somebody faces psychological issues in a palliative care setting? Sometimes we might give false reassurance with overtly positive statements. And I think all of us can identify, having seen sometimes being in the rounds, and you might be seeing colleagues who are not very sort of conversant with symptom management. They might focus on numbers. And also, you might actually selectively attend to physical symptoms and not psychological symptoms. That again sometimes happens. So these are some of the barriers which and common approaches which sometimes people take. Now, for the assessment of depression treatment, I will we have around 91 participants. uh, let's so if we even if we so if we divide the the group of 90 people, so those with starting with A to M, the names. If you look at the scenario one, so scenario one is 49-year-old lady with ER positive metastatic breast cancer, who is now admitted in the medical oncology ward, is referred to you as she has been frequently crying, her sleep is fragmented, and she has also expressed that she would rather die and end her life than prolong it by further palliative chemotherapy. What will be your approach? So yeah, can you Arun, can you make me the host again or co-host? Because I can't
Sorry, sir.
screen
Just a
share.
minute. Just a minute, sir.
So any takers that who would like to discuss this first case, you can take 5 minutes. And the second patient is anybody wants to read it out of the students who are attending. It's there in the chat box. Okay. So Aisha Osman has said, okay. So
So
I,
Arun, we have students, MD students, so we should ask them to discuss this case. Okay.
yeah, I think that's absolutely fine. Aisha Osman has said that we should explore why she is crying and maybe she's worried about the side effects of chemo. Absolutely. Her pain should be, Moshumi has written that her pain should be managed and explore her emotions. Sleeplessness should also can be managed. So what we don't understand is that which case are you talking about. So this is the first um, scenario. So let's go one by one. So if you can unmute the participants and ask someone who wants to talk about this.
I think they can unmute themselves if they want. Nisha, I don't have the co-host permission, so I can't
Yes,
unmute anyone.
yes, Dr. Arun, they can unmute themselves and participate in the discussion.
Okay.
They have the permissions.
Okay, thank you.
So I can see Mosumi, Nitu, they are there. You should ask Nitu and Mosumi, please start talking. Start answering.
We have a case of 49-year-old lady with ER-positive metastatic breast cancer admitted to medical oncology ward. She has symptoms as frequent cry, fragmented sleep. Also, she has expressed that she would rather end her life than be prolonging it by further palliative chemotherapy. So here we
That's
can.
why he is crying. So, and by stepwise, we can go through his emotions, go through our emotions.
Okay.
By exploring means what's exactly going in her mind is here.
One after the other, please. One person should talk one at a time.
Okay, ma'am. Okay.
Uh,
Thank you.
okay, Nitu, finish this and then Mosumi will talk.
So
We can go with an assessment of symptoms like she has frequent cry. So we can see here that she has got somatic symptoms here, and she's got vegetative symptoms as well. Her sleep is also fragmented, and she would rather die, which states that she has helplessness, worthlessness, and hopelessness. That she has got depression. And she also has decided to end her life. Because she has suicide ideation as well. We can know at this stage that she's suffering from severe depression in this case. So along with counseling and psychotherapists, we should give her medical management, pharmacological management as well, because she's suffering from severe depression. Thank you.
Okay,
yeah,
Mosumi, go ahead. Yeah, Dr. Soumitra, please go ahead.
Ma'am, I think if she has pain, then pain should also be managed. She has sleeplessness, that can also be managed. And after that, we can explore her emotions and can assess her depression and treat her accordingly.
yeah. So I think both of you have summarized. So the task here, if you get such a referral, the task here is to first make a diagnosis. And I think, both of you are on it. So I would do these things. I'll do a quick assessment when you're in the ward. See, I think, whenever I go and see a patient, I always look at the past notes initially. And if she is admitted in the ward, I would also ask the nurses about how she has been. So So is this crying only because, yesterday was her son's birthday and she couldn't attend, or has she been crying frequently for the last few days? Because when you make a diagnosis of depression, I think it is important to see, the duration criteria. She has also talked about ending her life. So I think, it's important, as you have said, look at the depressive symptoms, do the risk formulation. So how to go into the details of, has she been thinking of how she would end it life? Has she in the past ever done it? Is she depressed? So when you do suicide risk assessment, you actually assess 5 things. One is, does she have a psychiatric diagnosis? You look at the demographic variables. Sometimes, particularly olden days, people used to think that, males in their middle ages are at a higher risk of actually carrying out a completed suicide. And then you look at the suicidal thought or intent. So, have they thought of a violent means? Have they actually written a suicide note, a goodbye sort of thing? So standard, some information around the act of suicide. And then you see what are the level of social support and what is the medical comorbidities. So if you remember these 5 things: socio-demographic, psychiatric diagnosis, details around suicide, medical diagnosis, and social support. These 5 things, if you do, and also I can tell you there is no scale in the world which would actually be able to differentiate that score. More than 8 out of 12 means that there is higher suicide risk, and less than 8 means less suicide risk. Even if you have none of these factors positive, but you have just suicidal ideations and you want to end your life, you are still at a higher risk. So when you do around risk assessment in suicide, you have to understand that word assessment here means assessment and management. There is no prize that, oh, I told you so, when you go the next day she has killed herself, and I told you so. That's not how the word assessment in psychoanalytic framework, the way it is used is, assessment means that you come out with an action plan, what to do if you have somebody's at higher suicide risk. So for this lady, we would address, as you have said, that we would assess the unmet physical needs. Some of you mentioned about pain, and we assess the mood symptoms. One of you have said cognitions, biological symptoms, somatic symptoms of depression, and the duration of symptoms. You treat the physical symptoms. Risk management involving the family. Speaking to the family is very important. If the family is there with the patient in the ward, treat the syndrome of depression, make a plan, and discuss with the oncology team, because that's the place where you might be finding the patient and the patient is admitted in. So I think what you have, both of you have done, if you both of you were my registrars and had seen the patient, I would be happy, because between both of you, you have covered most of the things. But if you have this structure in mind, then that would help. So, okay, anybody in the audience who would like to do the second scenario? So this is a 73-year-old man. Any of you want to read it out, or?
So any student, Rabia, are you there?
Yes, ma'am.
So go ahead.
The scenario 2, 73-year-old man with prostate cancer who is referred to you with for extreme pain in both lower limbs that is not responding to opioids. He is tearful at times and especially at night. He feels tired in the daytime. In the periods when he is pain-free, he is able to watch the cricket match sitting in the lounge of the ward. What will be your approach to this patient? So, according to the assessment, as Sir said, we can actually go for the socio-demographic data, like how is the patient throughout the day, how was he in the last few days as well as in the last week. So, if you look into this case, he is a known diagnosed as prostate cancer. He has bilateral lower limb extreme pain. So then, right now you can focus on the pain that is not responding to opioids. He's tearful at
Absolutely.
night.
So, Dr. Sushma is there and you are doing palliative medicine. So you need to look out for a 73-year-old man with prostate cancer. What could be the common causes of pain? So what could be the common causes of pain?
So Rabia, go ahead. You are asking Rabia or me?
Yeah, Rabia.
Rabia, go ahead. It has gone. Nitu, Masmi.
Multiple reasons. It can
Hello,
either be the
hello.
Yes, Rabia, go ahead.
Yeah, ma'am. Actually, this is a case of prostate cancer, and he has bilateral lower limb pain. So that can be like it can be a metastatic skeletal lesions. The lesions have been involving the spinal cord, mostly in the lumbar or the sacral region. The pain is radiating to bilateral lower limb. So this can be a case of metastatic prostate cancer with skeletal metastasis that is not responding to opioids. So this can be that he's feeling a low mood because of the extreme pain, which is not responding to the opioids which we have been prescribing. He's tearful at times and especially at night. So he's sleepless at night, probably because of the extreme pain. He feels tired in the daytime. That can also be correlated because he's not sleeping well because of the extreme pain. But the highlight of this case is that he is able to watch the cricket match sitting in the lounge of the ward. So he does not look like a depressed person to me because there is no anhedonia. He is actually enjoying a pleasurable activity. That is one of the criteria of DSM depression criteria, that the patient should not have a pleasurable, not feel pleasurable while doing some entertaining activity. So this does not fit into a depression DSM criteria. So for this patient, my first approach will be pain management. Maximize the opioids dose, increase the NSAIDs, increase all the anti-inflammatory agents, give him a dose of Dexa, counsel him. So first of all, my aim would be pain management.
Absolutely. Very well said, Rabia. So,
Thank you.
sorry, what is your name?
Rabia, sir.
Rabia, yeah. Rabia, so, I think the approach would be very similar what you have said. And, you assess the unmet physical needs, which you have done.
Yes,
You
sir.
do assess if there is a low mood, did that start before the pain or after the pain? In this scenario, it looks like that he becomes low only when there is pain.
Yes, sir.
And you do a risk formulation like any this thing, assess the mood, cognition, biological symptoms, which may not be there in this patient. Again,
Yes,
you
sir.
treat the physical symptoms. Now, for a 73-year-old man, what you need to also look into, I think, when you do an assessment, it's best to do complete. I would also look into I'm not going into a discussion of what are the physical causes of pain, metastatic and neuropathy and all, because, that's not the focus of today's discussion. And I'm a psychiatrist, so my focus is teaching you psychiatry. But, you do need to know what are the other causes of pain in a patient with prostate cancer. But I think you need to know the comorbid medical conditions. See, there are in psychiatry. So, when we were talking about the first lady, 49-year-old ER positive tumor, um, you did not the students did not mention that in ER positive sometimes patients are on tamoxifen, isn't it? If they're premenopausal. Now, so I would check the menopausal status in that person. If the person is post-menopausal and is not on tamoxifen, that's fine. Whereas if the patient is on tamoxifen, my choice of antidepressant will change. And I'll ask you, any of you, do you know the drug interaction between tamoxifen and SSRIs? Similarly, in the 73-year-old man, I would see, does the person have a sort of hepatic dysfunction or liver dysfunction or a cardiac problem? Because these would, in a way, dictate my choice of medications both for pain and for depression. Now, but I would agree that with you that in the second scenario, the physical symptoms, sort of is more important than the psychiatric syndrome. Because when the pain is not there, his mood is not low. And you have correctly pointed out, that's the case. Anybody is aware of tamoxifen and SSRIs, the interactions? Okay, so I will tell you when you talk about tamoxifen comes into it's an anti-estrogen. So ER positive breast cancers are estrogen dependent breast cancer. So if people are exposed to estrogen, the cancer grows. So tamoxifen goes into the body as a pro drug. And also you have to understand that a metastatic breast cancer is advanced but may not be a terminal event. So with treatment, people can have even years of life. So that's possible. Now, tamoxifen, because it goes as a pro drug and the hepatic microsomal enzymes converts into an active drug. So if there is a medicine which actually inhibits that process, then your body will not get the active drug, tamoxifen. And that's a very serious issue. So you choose an antidepressant which has less propensity to increase the hepatic microsomal enzyme activity, which has less propensity to inhibit the hepatic microsomal activity. And for that, the drug of choice is often venlafaxine. Citalopram can be used, but it's very difficult nowadays because escitalopram is available. So getting citalopram in the market is not easy. So we often use venlafaxine for this thing, and of course, psychological treatment is important. So I would. And the other way to choose an antidepressant for the first case is, if there are some antidepressants which induces sleep. So if sleep is fragmented, you might choose a certain antidepressant like mirtazapine or sertraline if you're looking at an SSRI. Whereas if sleep is normal, escitalopram is fine. So you choose the common antidepressants, look at the side effects, look at the person's this thing. Also, when you choose an antidepressant, I think it's important to look at the 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 age of the person. There is some data to show that sertraline works very well for middle-aged women. Now, what are the depression risk factors in palliative care setting? I said that I will talk about gender after some time. So, the traditional teaching has been that women have more depression, and which is true in general population. And that could be for various reasons. One could be that, in middle age, women may have certain biological factors working in them. There could be also a social factor, which is very true in our country, that women folk in India are going through an immense amount of stress and tough time, because we are at a cultural threshold where you have to fulfill the roles of a traditional homemaker, be at the same time a professional, earn money, be able to be a perfect mother. And this is a difficult role, this multitasking to fulfill. And there could be other problems of lack of empowerment of women. So I think in India, it's a very real issue. And in fact, data in India shows, when you look at, we are talking about depression risk factors, but when you could also look at risk factors for suicide. And the traditional teaching used to be that women attempt suicide more often, but they don't have completed suicide, whereas men may have completed suicide. I think the current teaching is that women and men in India, the risk actually is very similar. It's not that you should take suicide attempts in women lightly. So I think any suicide attempt, you should take it very seriously. And age for palliative care, depression is commoner in younger adults. So less than 45 years of age, people have higher risk factor for depression who are getting palliative treatment. These are all backed by data, but I'm not giving you references here. But if you look, these are the reviews you will get. If there is a past history of depression, again, that's something which you should cover in the history with the beginning, when the person has been coming to the ward or into your OPD. Poor social support networks, and if there is a functional disability, so the person is unable to go to the toilet, person needs help to get his activities of daily living, and pain, if they have pain. So these are things which should keep you, trigger yourself that in this setting, depression is common. I should be keeping my threshold low. And once you have seen this, you do need to look at, the side effects of the medications which might be there, and choose the medications depending on there. I look at, the medical comorbidities, and LFT and urea creatinine is commonly I look at, because, that may, change the medications I choose for. Now, I know when I look at the your emails for these morning sessions, I see there are quite a few issues on psychosocial interventions in palliative care. So I wouldn't cover on that. So I have focused depression and medications in my presentation, but psychological treatment is important for everybody. And I know Mr. Ganapati is there. He had been talking about communication in adolescence. So adolescents and children also requires to be handled carefully. So you need different strokes for different folks, and young patients, adolescent children, very old patients, patients who have multiple morbidities, these are vulnerable groups. Patients with learning disabilities, again, these are vulnerable groups. Now, the consequences of managing depression better is that you have better physical control of physical symptoms. You might be able to address existential concerns regarding, if the patient has these questions, why did this happen to me? Or it also, managing the depression, it has better coping, and you have more satisfied patients and family members than if you leave these unattended. And believe me, addressing these are not very complicated. You have to just be mindful. And I can see for all of you who answered that all of you have given some thought on the psychosocial aspects of care. You have told me answers more than any medical group I usually interact with. So I think things are changing, and India, I don't think, will ever have enough number of psychiatrists to be involved in all palliative settings. So I think all of you who would be the future leaders for palliation should have some understanding about the physical aspects of palliation and the psychological aspects of palliation. So I think it's important. I'll share with you, paper we just published last month, which was about the psycho-oncology services in our hospital pre-COVID and during COVID. And this sort of reflects our practice. So if you see, our common antidepressants which we had used were escitalopram, sertraline, mirtazapine. So these were some of the common antidepressants. However, if you see, if all the patients who were referred to us, around 50%, so did not have any psychotropic prescribed by our team. So not everybody needs a medication. So half of the patients, and in 2020, actually, around 60% had not had psychiatric drug prescribed by our team. And also the dose of medication, if you see, so if you are treating someone who, because in oncology, and there is evidence on that as well, so if the therapeutic dose is, say, an average person with depression requires 100 milligrams, 50 to 100 milligrams of sertraline, a person with cancer might respond to a lower dose. So even at 50%, they might respond. And because, by the time you are seeing them, they might be on multiple pain medications, they may be anyway sedated. The idea is for them to be pain-free, for them to have a reasonable, satisfied life and feel happy, but be awake and alert and be interactive with the patient's families and the staff. So that's the goal. So I think it's important that we don't give too much medicines in terms of dose. So if you see, 50% of our patients, when we did this audit, responded to below therapeutic dose. So that's again something, and 50% were in the therapeutic range. None of our patients in any of the years, if you see the last row, 0000, needed medications above a therapeutic range, the usual therapeutic range. Now that may be different from if I was in a psychiatry hospital where, treatment resistant psychosis, schizophrenia, bipolar might come, and you might require much higher dose. But in a cancer hospital, that's not the usual scenario. There might be exceptional one or two patients, but usually that's not the case. Now, when we talk about psychological interventions, yes, some of them did not have any psychological interventions, but the interventions which we found when we did the audit, some of them were very simple. Some of it was just educating the person about the condition and what they need to do. So sleep hygiene techniques, things like that, and educating about depression and early signs of relapse if they've got better. Getting the family to be able to say that, keep the person involved in their day-to-day activities, allowing the person to express their worries. So ventilation, of not the ventilation which you guys talk about. I know many of you may have a background in anesthesia. Ventilation in psychological world means that you allow them to talk. So expressing their worries, providing support to the family. That's again very important, because in our country, families are the primary source of caregivers, and they might go through guilt. They might be upset that they are not doing enough. So supporting the family members. Some family members also require formal psychiatric assessment. So I think that is not uncommon in a setting like ours. And providing therapy to the patient, formal therapy, so CBT. So if you see, around 20% of our patients required formal psychological therapy in that sense. And environmental modification, because this paper was about not only depression, other things, so delirium. So environmental modification in a person who has delirium or dementia also helps. So if you see, my message to you as young budding um, uh, palliative medicine physicians is, if you get the simple stuff right, I think you will get it right. Getting the complex stuff right, you can always refer them on to a specialized psychiatrist. But you need to get the simple stuff right, and that would, get you, a lot of this thing. As I had said, this I guess this recording would be there, and I have sent the slides to Nisha as well. So when you talk about medications, common medications are escitalopram, sertraline. If you choose to change the group, particularly if it has not responded, you go to venlafaxine. Sometimes elderly people respond well to mirtazapine. See, I personally feel that when a person does not respond to antidepressant medication and they are still continuing to have low mood, usually there is a psychosocial stressor which needs addressing. It's not, there are psychiatrists who would believe about serotonergic depression and noradrenergic depression, but I think, yes, that's a possibility. But primarily the common reasons are that they are worried about, that their the money the family has spent could have been spent on the son's education, or they're worried that because of the stigma of ovarian cancer, her daughter will not be getting married. So something like that. Or daughter would not be able to get educated. I shouldn't be gender stereotypes. So whatever, those things needs to be addressed in the intervention, in the interactions you have with your patients. And you check with the patient, uh, if they are already on amitriptyline, venlafaxine, duloxetine, because these are again medications which are commonly prescribed for neuropathic pain. Now, when you give somebody treatment, so I went to Primasha, our inpatient palliative care ward, on Saturday, and um, I saw that somebody had actually given amitriptyline because the person had been on pain, and there were also other medications. So if that person had needed an antidepressant, I would have stopped the amitriptyline. So you shouldn't give escitalopram while the patient is already on duloxetine, because having two antidepressants can have noradrenergic syndrome, serotonergic syndrome, and also other drug interactions. So uh, cholinergic syndrome. So I think it's important that you give one antidepressant to one patient. Usually, patients do not require two antidepressants. Being mindful of the inhibition of cytochrome P450, as I had said, paroxetine causes this most. I usually avoid paroxetine because it has other side effects as well, and has a bad withdrawal symptom. Be aware that fluoxetine is mostly, the SSRIs have a half-life of 1 to 2 days. So fluoxetine has a half-life of few weeks, up to 8 weeks. So if there is a side effect with fluoxetine, see, don't get me wrong, fluoxetine is a very good drug. As a child psychiatrist below 18, fluoxetine is the only licensed antidepressant in the UK to be given to people below 18. So it's used, and I used to use it, but in a palliative setting, where if there is a side effects, you have to remove the drug, or you need to be in a position that the drug has been flushed out of the system quickly. Fluoxetine does have a longer half-life, so you need to be aware of that. I have already talked about serotonergic syndrome and trying to avoid drug-drug interaction. I don't think it's humanly possible to actually memorize all the drug-drug interaction. I think in today's world, gone are the days where medicine was knowledge based. You do need deep knowledge about what you do, but it's not information based. Medicine is, so informations can be checked. So there are very good online drug interaction calculators. So if you are in doubt, or if the patient is on a new immunotherapy and you don't know what is the interaction of that immunotherapy with your medications, you just check the drug interaction, and and they're quite well updated. So psychological treatment, they do complement medications, as I had said. You need to ask the patient what is their preference. That's crucial. Patient choice is crucial. And like medication, psychological treatment also needs to be graded in depression, in palliation. And now we have seen that actually a telephone-based therapeutic intervention or psychological support actually may work wonders. So COVID, although is a really difficult time we are going through, but also has given us an opportunity to see what are the ways that you might deliver psychosocial care to this group of patients. And this is going to stay, I think. So coming to the end of my talk, so I would say that depression is common in palliative care setting. How common? So there are studies which talk about 3% to 40%. So roughly the consensus is around 1/5 of the patients, so 20% of patients might have depression. And it is important to identify and treat depression. I think after this talk, you would understand what are the values, and it's not very difficult to identify and treat it, and how to treat it. And being able to address the psychological issues in palliative care, you need to have capacity building. So in terms of empowering nursing staff about how to recognize depression, and alert you when you go for their next ward rounds. And once you identify, it's not very difficult to treat it among so many other symptoms which might be difficult to treat. So with that note, I would end today's interaction. Any questions you might have, I would be very happy to talk about or discuss. And there are other senior members, Dr. Bhatnagar and other faculty. We can all, Arun is there from TMH Bombay, so we could all address them together. And I know Mr. Ganapati as a psychologist is there. So over to you.
Thank you. Thank you very much for the excellent lecture, sir. There are two questions. So I will just go through question number 2, and then we'll go to question number 1.
Yeah.
So, yeah, thank you. Sir, the question is from Dr. Kahakasha. She is asking how to address psychological impact of morphine treatment.
Okay. So, morphine, you shouldn't only think about morphine. So, opiate. Now, you need to understand that our body actually produces natural opiates and endorphins. So they are not one of the medications which are known to have terrible psychological impact. So I think the psychological impact which I have seen most common with opiates is that people are scared of opiates. That, if you are on morphine, it's like some people have a stigma of morphine. So I think the first thing as palliative medicine physicians, which you should do, that, that if somebody needs the opiate and, step 3 analgesics, you should demystify it and say that it is essential. Because if you do good quality cancer pain management, it's a different person after a few days. I often say that in cancer, when you do cancer specific treatment, so chemotherapy, where the body cells are, the way I explain is, the body cells are dividing fast, and in cancer treatment, you have to target those cells. That's why there is side effects more. So, you may have hair loss and things like that, reduced neutrophil counts, being prone to infections. So cancer treatments usually have more side effects than non-cancer treatments. And the medications which often we use in psychiatry or for palliative medicine actually have less side effects than many of the medications the patients have already gone through. So these are common. So this is the first premise I would say, that don't make the patient panic about side effects, psychiatric side effects of morphine. The common side effects of morphine, I think, the constipation and sedation, these are common, or nausea, vomiting, these are common. So you give medications for that. I don't think, if the person's morphine dose is titrated correctly, it's very common to have opiate induced depression or other mood disorders. If you give it a bit more, patients may be slightly delirious. That's sometimes seen. So then you have to reduce the dose, change to a different opiate which has shorter half life and things like that. But producing classic depression, anxiety, psychosis because of opiate, it's very rare. What's the
Okay.
next question?
Yeah, thank you. The next question is from a resident. She's asking, what can be the simplest screening measure for depression when they work in wards?
Okay, absolutely. It's a very good question. I think there is the tools which people talk about in textbooks is very difficult. Nobody uses them. I'm telling you, I have worked in reasonably good settings around the world. Nobody in the world goes around using hospital anxiety depression scale or Beck depression inventory. It's just not possible in a regular clinic. And nowadays there are even publications to say that these some of the tools are not feasible to be done. There is a lot of talk about distress thermometer, and I'll talk a little bit about that. But if you ask one question, so the two question screening, that how do you feel in your mood, and the person says that I feel low, and then you ask about depression. So if you directly ask, how have you been feeling lately? I think that's one of the best screening measures you might have. Vikram Patel has, publications even on two question screening. Now, if you are talking about scales, so I would use that. How has your sleep been? So ask one or two biological symptoms, screening question. So that's the good indicator, and it's non-threatening. So if you ask somebody is in your mood and you're in a hospital admitted getting chemotherapy, of course nobody is happy about that, and people might feel a bit intimidated. So the first question I often ask is, has your sleep been lately in the last 2 weeks? So that's a good question. And how have you been feeling in your mood? If you ask these two questions, most patients would open up and you can go into their sort of psychological domain. Now, in terms of specific psychometric tools, and if you want free ones, so there is a tool called PHQ-4, which has only 4 items, and that's easy to use. And distress thermometer, which you might be aware of. So it's like a visual analog scale, 0 to 10. And the advantage of distress thermometer is that on a 0 to 10 scale, if somebody is distressed, nobody is at distress 0, not even the people who are attending this website. If you go into that webinar in the last 1 week. So if there's 0 to 4, I would say this is fairly generic, whereas 4 to 6, require some psychological interventions. Above 6, so 6 to 10, you might require formal psychiatric interventions, medications, a specialist care, some sort. So distress thermometer, PHQ-4, people talk about, but I would go about, the how is your sleep and how have you been feeling lately in your mood. So, 2 question screening. Google Vikram Patel and screening, brief screening for depression, and you'll get articles by him. Thank you.
Thank you. Thank you very much. The last question for today, because it's 7:30, the last question.
Yeah.
From Mr. Ganpati, how do you differentiate depersonalization and depression in the actual palliative care setting?
Okay, so depersonalization is the person, this is phenomena. So derealization and depersonalization are two phenomena where the person feels that I am not real. It's rare, it's not very common. And derealization is about this person, the setting they're in. So you go by history and what exactly the person has been feeling and see if it fulfills the criteria for any of these two phenomena. It's possible to have that depersonalization, but it's not very common.
Thank you.
Thank you.
Thank you very much. Sushma madam, I think we can conclude for today.
So I think thank you very much, Dr. Dr. Datta. You have really elaborated nicely, and I think in a very simple terms you have explained how to assess and how to treat depression in palliative care setting. I wanted to share a lot of things, but I think time is less. But I will take just 2 minutes. That the important point, which first question which have been asked, that what is the psychological issues when we start morphine? I think every prescriber, if they will sit 5 minutes extra, because whenever we start morphine, even if somebody will start morphine on me, I will have certain certain thing to think that why they are starting morphine. So if we will spend extra 5 minutes, that why do you need morphine right now, and if we will not give morphine, what will be the problem which we can anticipate. So it is not a drug which has something stigma. You have to give 5 minutes, then there will be no psychological issues in patients. And for this we have created printed instructions. So we explain them for 5 minutes extra, and then we give that printed instruction to the patient that this drug is used only for you, and it is required for you. That's why we are starting, and other things, all other safety measures. Second, which I want to, you have given a lot of emphasis on simple measures. I think simple measures really makes a lot of difference, and which I have experienced in palliative care a lot. But in COVID, we have experienced it so beautifully well, that in first COVID wave, people used to be very mild to moderate, and they used to be very, very depressed, and they're very anxious that they are going to die, because COVID means people think that they are going to die. So I have given a lot of importance to residents that please go and talk to every patient and give only two information, that this is a simple disease to treat and we are doing our best. And in case, because they are alone, they are in quarantine, and people are, doctor and nurse, they will not come frequently. So in case if you have any issue, please call on this number. We are always available. So this measure really worked a lot. In the second wave, what happened, that suddenly 100 patients every day coming, it was a nightmare for first 15 days, that a lot of complaints are coming from the relatives that my patient has gone inside, nothing has started, he is breathless, and minister is calling, IS is calling, all sorts of complaints we used to get. But within 15 days, what we have realized, we used to send a message to the relatives that your patient we have admitted, we have started treatment, and he is on bed number so and so, and if you really want to know about the whereabouts of your patient, please call on this number. Suddenly it has become so peaceful, no complaints, everybody was settled. So simple measures, just means like what we have done round we have to do, and we have to just take extra time just to explain two things. And similarly for caregivers, we have to explain that they are not anxious, they are not depressed, they are not having some psychiatric issue, but they have genuinely, they are worried about their patient. So you have to just 4 lines of message has done miracle. And I have asked one of my residents that how we have changed the scenario with 4 lines of message. We should publish this. So simple measures really makes a lot of difference. And you have talked about the drug interaction. I think it's so beautifully well that it is important that what patient is taking, then only we should write medication. Thank you very much, Dr. Datta. It was a wonderful lecture, and everybody must have enjoyed. We will see you next Monday, all of us, and thank you very much for joining. And I really again regret that I have missed so many classes, important classes, but I will definitely see all the lectures. I will take from Nisha and I will see all the lectures. Thank you, Arun. Thank you, Nisha. Thank you, Dr. Nagesh, once again for taking care of all the lectures when I was not here. Thanks a lot. Thank you very much.
you.
We'll see you next Monday.
Bye-bye.
Thank you. Thank you.
Thank you.
Thank you, Soumitra. Have a great day.
Thank you, Mr. Ganapati.